we have Dr. Manjri's slides on, please? And then we can request Dr. Manjri to share his screen.
I'm sharing, Dr. Agarwala.
Okay. All right.
Can you guys see my screen?
You, but I mean, we've interacted over years. We've been abroad and interacted over years. And Professor Manjri has an outstanding amount of experience with sickle cell disease, something that is there in India, because as some of you may know, the sickle cell disease gave malaria patients. Sickle cell prevented malaria patients getting worse, because then by natural selection, Darwinian natural selection, in certain parts of India, sickle cell is prevalent. So we do encounter patients with hip problems, AVN, due to sickle cell disease. And so Dr. Manjri will share with us his experience with sickle cell disease, which is a unique spectrum of this disease condition. He has interests in, of course, replacements. He has research interests in functional outcomes, hip and knee replacements. He's authored multiple articles. Can you see the next slide of Dr. Manjri? He also designed and patented a proximal tibial retraction device, and he's received various awards. He's an active member of the Saudi Orthopaedic Association, served as president from 2008 to 2018 for the Association's Arthroplasty Wing, and he's been an examiner on the Saudi Board of Orthopedic Surgery. So, Dr. Manjri, may I request you to kindly share your presentation with us?
Okay. I think I did. Nikita, I did share the slide, did I? Okay.
No, Nikita will let you come in.
Okay. Am I okay to go?
Yep.
All right. Well, thank you very much, Dr. Agarwala, Dr. Okankar, and various members of the ISHKS organizing committee for inviting me for this wonderful session of a vascular where we learn from each other so much. Well, sickle cell disease is basically an autosomal recessive disorder. The prevalence is 1.2 to 40%, and this goes depending on which part of the world you're looking at. So it's very commonly prevalent in the mid-African desert and the mid-African versus the Northwest Africa, with a lot of malarial prevalence. And as you said, historically, the presence has been as a protection towards malaria, but that's only by the heterozygous sickler. The homozygous sicklers do not offer any protection to malaria. There's also a common belt between the eastern part of the Arabian Peninsula going all the way to India, as well as the southern, southwestern part of the Arabian Peninsula. The main pathology in sicklers are substitution due to a mutation, a genetic mutation leading to a substitution of one of the amino acid, which is valine to glutamic acid. And that gives a very abnormal morphological structure to red blood cells when it gets deformed from the usual spherical biconcave to a crescenteric sickle-shaped type of cells that's not able to go through microcirculation in situations of being underhydration or deoxygenation. And the commonest pathophysiological process in sicklers are vaso-occlusion, and this will result to end organ damage, pyogenic infection, hemolysis, and most commonly vascular necrosis. Hydroxyurea has been a medical breakthrough advancement in sickle cell disease, but that has not helped in minimizing the incidence of avascular necrosis. It has helped only in reducing the frequency of vaso-occlusive crisis attack. If you look at this slide, it shows different types of sickle cell disease depending on phenotype based on different genetic distributions. So they have got 4 kind of African haplotype or subhaplotype, and one which is the most mildest is the Indian or the Indo-Arabian haploid. And this is characterized with much more milder presentation, higher frequency of vaso-occlusive crisis, as well as splenomegaly, but patients do live longer and live relatively lesser of a medically compromised life compared to their counterparts who are suffering from the African type of haplotype. So the vaso-occlusive crisis or the vascular-necrosis in these sicklers are results of multiple attacks of vaso-occlusive crisis associated with intravascular thrombosis. Usually they're bilateral, and almost 40% or more of the head is involved, and not very infrequently, almost half of them or more do progress into femoral head collapse. The incidence is about 24%, and this is from a study in Saudi Arabia, but there was also a study in Nigeria where they found the vascular necrosis incidence to be as high as 47%. There's slightly female dominance, 57% female versus 43% male. And as I mentioned, they're not related at all to hydroxyurea. Up to 25% of these cases will have bilateral involvement contralateral hip. And 25% of these cases, by the time they get a vascular necrosis, they also have disability. I mean, it's physical disability. Philippe Harnagot had published extensively and studied extensively in patients with sickle cell disease, and they published a national history of asymptomatic avascular necrosis in patients with sickle cell disease, where they showed that the very milder version of them might not progress to becoming symptomatic, but the wide variety, which is stage 1 to stage 2 and 3, do become symptomatic within the first 3 to 5 years. And once they become symptomatic, the natural history is depending on what stage of disease they are, the maximum window that you have is about 43 to 45 months by the time they require some kind of surgical intervention, which is defined as a clinical failure. In their series 88 out of 92, that's about 96% of the symptomatic hips did deteriorate, and those who were in stage 3 or 4, which is basically femoral head that had collapsed, within 10 months require some kind of surgical intervention. And this is a graph showing the involvement of stage 3 and 4 much more earlier within the first year, and stage 1 and 2 takes a bit longer, but eventually even the mildest of those cases would require some kind of surgical intervention within 5 years of duration. This is a case that clearly shows the progression within less than 10 months. This is a 20-year-old lady I saw back in December 2019. And then from just X-ray that was done last week, you can see the degree of collapse that she has on her right femoral hip. She's already gone from FECAD stage 1 to 2 to almost pre-collapse. She already has a subchondral fracture in her right femoral head. Very interesting finding in these sicklers that I've found in my practice is their association with sacroiliac disease on the affected side. They commonly have got some kind of symptoms coming in the right buttock, which is commonly mistaken by our medical colleagues as due to their avascular necrosis. But a lot of them, particularly those who have normal or near normal hip exam, do have a very positive sacroiliac joint exam. They have positive figure of 4, and they respond very well to joint injection in the sacroiliac joint. So what about the treatment for these patients? Obviously, as everybody mentioned, these are younger patients. We would like to do our best to minimize the need for total hip replacement. Shockwave has been successful in the very, very early stages. So those who are stage 1, bisphosphonate in my practice has not been very successful, and that could be because most of the patients
so they have an India, and by December it will become worse.
Okay.
So please could you take those tablets?
Nikita, please mute yourself.
Bisphosphonate could be because most of my patients are already advanced and they're coming in stage 2, and they're either pre-collapsed or already collapsed. So I don't personally start them on bisphosphonate, as by the time they have been referred to me by the hematologist and in association with endocrinologists and rheumatologists, they have had some course of bisphosphonate, but as far as I've communicated with our colleagues, that they have not been very happy with the outcome of bisphosphonate in this group of patient population. Activity modification, it works for the acute attacks of vaso-occlusive crisis. We definitely avoid any kind of non-weight bearing. If you do that, they usually keep their hip in flex position, and very soon they come back with a stiff hip and a fixed flexion deformity. So we just allow them to get up and walk with weight bearing as tolerated with a strong analgesic intervention. I personally did some core decompression in patients stage 2 and stage 1. This is before we had access to the hard and hard bearing surface and the implants that worked for the younger patients, as well as the DDH type of implants. I have to tell you that my best patient who survived core decompression was only 2.5 years. And after that, I had to convert them to total hip replacement. And you got to understand that most of those patients are young. They want a single procedure that will give them a very predictable outcome so that they can enjoy their professional and personal life. I don't have any experience in stem cells, but one of the universities in our city are doing some trials in stem cells with sickler. Concern about total hip arthroplasty in these particular group of patients are because of their comorbid medical issues, their high likelihood of getting infected, and also the dilemma of using what type of fixation, cemented or uncemented. Clinical reports in total hip arthroplasty has not been very much. They're quite variable. And majority of those patients are young, so there's always this concern of having them get a revision once or more in their lifetime. This table will show you the various results that came out from different series of total hip replacement in sickle cell disease. And they're anything between failure of 40 to 50%, but majority of these cases have got follow-up of less than 10 years. I think the biggest problem in these patients, and we need to look more of a holistic approach and take a step back from being a joint replacement surgeons. These patients have got pain, and we got to help them in taking care of their pain. They're young patients. They would like to be very active member of the community and of their society. They want to go back to their job. They want to finish their education. They want to start a family. And their biggest concern is pain. We got to try everything possible to wean them off from any kind of dependence. And therefore, assuming perioperative pain control has been a very successful factor in our practice when we applied total hip arthroplasty in these patients. There are preoperative issues, intraoperative issues, and some complication, as well as I'll brief you about a quality of life outcome in this particular group of patients. We are very strict in making sure that these patients do get admitted a day before. They get also seen by our hematologists about 28 days prior to their surgery. And upon their admission, we make sure that they're not suffering from any acute chest syndrome. They're not infected, and they're appropriately hydrated and oxygenated. We have completely stopped exchange transfusion, at least for the last decade or two. Keep in mind that multiple transfusion might give you some kind of alloimmunization into about 30% of those patients. Our hematologists are very aggressive in studying these patients on erythropoietin 6 weeks prior to surgery, and sometimes even 3 months prior to surgery if they were constantly having hemoglobin of less than 8. Infection has been reported up to 16 to 20%. Some of those patients do have chronic ulcer due to stasis in lower extremity that could be easily overlooked. There have been multiple recommendations of starting tafazil in 24 hours prior to surgery and 72 hours after surgery. Currently in my institutes, we do not follow this. We just give them the standard prophylaxis that we give for any other arthroplasty patients, which is 24 hours of perioperative antibiotics. Intraoperatively, do suspect a lot of bleeding from soft tissue that are scarred, as well as from raw bone surface. Tranexamic acid has been a game changer for us. There's definitely a lot of anatomic abnormalities. There could be due to multiple soft tissue adhesions. There could be abnormal location of neurovascular bundles. You got to watch that. Hip center of rotation is often displaced, and more or less they always have some kind of limb length discrepancy. On top of that, these guys do not tolerate any leg length discrepancy more than 0.5 centimeter. They start getting numbness, paresthesia, and their acetabuloms are usually very small. I always like to have the DDH type of implants available when I do any one of these cases. Their femurs are small. They also have increased anteversion of their femur. There's always a small canal with multiple medullary osteonecrosis on top of the femoral head osteonecrosis, and that might lead to a perforation rate of anything between 5 to 18%. In doing so, I prefer to use large drills or burr to open up the proximal femur, just enough to I can pass a guide wire, and then I like to use my mechanized reamer over these guide wires to open the canal. And using a C-arm is a must for any case of sickle cell disease that is going for. There isn't any clear randomized control studies comparing type of fixation. There has been a report back in 1992 from Akoyo and Friedman where they noticed a better performance of their cementless cohort out of the total hip arthroplasty that they did in sicklers. Dr. Ilyas and Moro from King Faisal Hospital in Riyadh reported on their 18 cases of simultaneous bilateral total hip And again, they used entirely cementless construct on both sides, femur and acetabulum, and they had one deep infection only. Dr. Paul Lukowicz from Duke reported on 13 cementless total hip arthroplasty. And again, they did not have any loosening or infection. Again, Hernego has been one of the higher volume total hip surgeon in Sickler patient population. They reported on 312 total hip arthroplasty, probably one of the largest series in the world. And their complication were predominantly medical, up to 27%. They had revised 3% due to infection, 8% acetabular cup revision, and 5% femoral stem revision within the first decade of life. So these patients are unhappy. They have psychological issues. They need to be noticed as normal members of the society. A lot of those patients are jobless. They are not able to interact or be part of active society members. Some of them do get into chronic drug addiction. And therefore, we got to look for a very aggressive and a one-time solution. SI pathology, as I mentioned, that is something that we always need to be looking for in our clinical assessment. And also, these patients have got vaso-occlusive crisis that has affected multiple parts of their body, not only the hip. They may have pain from the lower back. They may have pain in their shoulders and shaft of their thigh, tibia. So you got to look for other causes of pain as well on top of the total hip that you'll be able to offer them. We did case control study, and I think I presented this, Hemant, when you invited me from the 2011 ISHKS in Pune. These were 46 patients, 18 of them were total hip and 28 were non-total hip patients. All of them were younger than 40 years of age, had the same kind of prosthesis. They were matched based on their preoperative functional outcome of WOMAC pain and WOMAC function. And what we noticed that 1 year post-op, both groups had very substantial and excellent improvement from their baseline scores, although Sickler had significantly lower scores, but in general, they have much more better than what they were preoperatively baseline. Those patients who were having monoarticular joint involvement, we did notice that post-op total hip, their attacks of vaso-occlusive crisis got much more less infrequent. So not only that the total hip helped them in taking care of the pain of the affected joint, but the fact that that pain was resolved gave them less attacks of vaso-occlusive crisis, which makes somebody think that presence of an ongoing source of pain could work as a stimulus for these patients getting repeated vaso-occlusive crisis. Our overall experience, 86 cases of total hip in Sicklers that were done from 2006 to 2019. We had one case of intraoperative acetabular fracture, one greater trochanter fracture that was undisplaced, one stem that was put in varus but hasn't loosened yet, 2 cases of infection that required 2-stage revision, 1 case of femoral perforation, and 1 case of aseptic loosening of the femur. And there was 1 case where the lengthening was more than 1 centimeter and the patient did not tolerate that at all. These are some cases. Again, these are the more, I will call them the benign Sickler, the good Sicklers that do not pose much challenge than the average usual total hip patients. A junior medical secretary had this in 2007. She did very well. This is a bad Sickler where you can see the degree of obliteration of the canal, obliteration of the acetabulum. You go in and you really have to struggle finding the right tissue plane, the right bony plane. This is a typical example where I had to use a hand reamer, and look what happened. It got broken, so I had to use those laparoscopy forceps to get that broken drill bit out. Case of aseptic loosening of the femur, 11 years down from her index procedure, required a revision femoral type of prosthesis. This case I'd like to highlight because of lack of knowledge on our side of some of our medical colleagues who do not differentiate between a bipolar hip and a total hip. This patient did not seek orthopedic attention for up to 12 years from her index procedure because her pain was constantly put as back pain, pain due to other causes, because the medical guys constantly kept on telling her that you did have a total hip, where what she had was actually a bipolar type of hemiarthroplasty and required obviously a revision. This is a guy with a 2-stage revision due to infection that he had. And again, even this gentleman was going here and there for up to a year because nobody looked into his hip. He was even booked by the neurosurgeon to have some back procedure performed, when in reality he had a staph infection. So I think in conclusion, total hip arthroplasty and Sickler demonstrates excellent clinical effectiveness. They're very good in improving their quality of life overall, as well as from their baseline scores. They are, though, inferior than a comparable cohort of total hip arthroplasty in general patient population. But certainly in my hands, I would recommend having a very low threshold on total hip arthroplasty in these unique group of patients because of the immense difference that I've seen in their overall general well-being, in them being able to lead a very happy and productive functional quality life that they do after they undergo a successful total hip arthroplasty. Thank you very much.
Thank you very, very much, Dr. Manjri. A very difficult topic, and I'm delighted that you could present the intricacies of the requirements for sickle cell disease, total hip, and how you had problems with even the marrow cavities and which needed drilling. Thank you. So we do have questions, but we must get Dr. Kumta to speak to us, and we're extending this session by 15 minutes so that there's adequate time for us to gain from Dr. Shekhar Kumta's presentation.
So do you want me to share my screen now?
So could we have Dr. Shekhar Kumta's initial slides, please, Nikita? And then there we are. Now, Professor Dr. Shekhar Kumta is a contemporary. We have missed him from India, but he is gone and made a name for himself and has contributed to science. As you can see, he is the assistant dean, he is a professor, and the executive director of the Center of Bioethics. He has been involved in the application of new technology in medical education. He has keen interest in bone tumor surgery and limb salvage surgery. He is a member of the board of the Chinese Musculoskeletal Tumor Society. The next slide, Nikita. Hundreds of publications. Next slide. Hundreds of publications, huge number of presentations, and we welcome you, Shekhar, to this webinar. Please teach us.
Okay, first of all, let me share my screen, and I want to I would like to thank Sanjay and Hemant Wakankar for inviting me to this presentation. And I must say, I learned a lot. It's quite interesting. And my background really is hand and microvascular surgery. And that is the reason why I inherited this legacy of using vascularized bone graft. And we do all our vascular reconstructions ourselves, including fibular and a variety of tissue flaps. So a lot has been said, and I completely agree with the earlier speakers. I think Michael Mont and others have really talked about pre-collapse disease. And I think one of the signs that we look for in the radiograph is the crescent sign, which indicates that collapse is imminent. And once you get a crescent sign, it means that there is failure of the subchondral bone, and you're going to get a collapse. In fact, that collapse can also lead to significant delamination of the head, as others have spoken about. So when you get a crescent sign, I think that's the time to act, and that's the time where you just can't wait and put them on non-weight bearing, etc. So you need some sort of intervention. It could be drugs, it could be decompression with bone grafting. I also want to say that there are a variety of classifications, and I really don't use any of the classifications. It's just that we look at the MR and we look at the plain radiograph and then decide if it's stage 3. Is it stage 3 where there is a crescent sign, but the head is still not deformed, or it is already gone, you don't see the crescent anymore, and there's loss of sphericity? I think that makes a very, very big difference. So stage 3A versus stage 3B. And nowadays, I wouldn't operate on stage 3B. It's probably too late, although sometimes your hand is forced, and I'll show you some interesting results. So once you lose sphericity of the head, it's only a matter of time that the acetabulum is going to get involved, and no matter what you do, it's almost impossible to restore the sphericity of the head, and outcomes are definitely not satisfactory. Our understanding of the pathology is no different from what everybody has said. There is an area of necrosis. It's a sector of the head that's involved. There is always a zone of hyperemia and remodeling. That remodeling is what often results in weakening and softening of the support, and the subchondral bone collapses. And you can see there can be various grades of collapse. Eventually, if we have enough time and the head doesn't collapse, nature will remodel and replace the necrotic bone. So to replace necrotic bone, you need osteoclastic resorption, and it is this race against time which fails because the subchondral bone undergoes fatigue failure. The underlying bone is avascular, doesn't remodel, and therefore it's only a matter of time. If somebody was to wait for years and years and years and non-weight bearing, perhaps you might get remodeling on its own, but it seldom happens. So there are key concepts in treatment that has influenced our understanding of management. First of all, there's necrotic bone that must be thoroughly removed. As a result, there is going to be a cavity, and that cavity should be filled with bone that has the best potential for remodeling. And in our case, we are very comfortable with the use of vascular bone grafts. People have used other forms of bone graft. They've supplemented, as you've seen, cancellous bone with a variety of other osteogenic stimuli. You can add BMPs, you can add stem cells, you can add a variety of artificial allogenic bones as well. So I'm going to take you through some cases. Here's a young man with bilateral head pain. It was worse on the left side. He had a short-term steroid use for a very, very severe exacerbation of asthma. He had no other risk factors. And I don't know whether you can see it, but there is a little bit of sclerosis but the pain was quite significant. So any young adult presenting with unprovoked hip pain, I think we should consider avascular necrosis. And at that time, he was still wondering, what treatments to do. He had sought help from his medical insurance provider, and over a period of time, his hip pain progressed, and you can see now he's got cystic changes, and it is almost there is a very clearly evident crescent sign. So we call this stage 3A. People will argue, is this pre-collapse? I would say this is, splitting hair. If you don't do anything, it's going to collapse. So that's the frog leg views. We also noticed that he had started to have mild hip pain on the opposite side as well. So that is the donor site. We take the ISHKS bone graft, and I'll show you a small clip of how we do that. Our approach is medial. So we harvest the ISHKS along with the deep circumflex iliac artery as a pedicle graft, so no need to do anastomosis. We go bang onto the medial side of the femur, just lateral to the femoral artery. So because we have to expose the deep circumflex iliacs, we expose the femoral artery, and the approach is very direct. And pretty much like the trapdoor approach, we make a trough on the femoral neck, not so much on the femoral head, but at the femoral neck and head junction. So here you can see a CT of the graft in position. The graft acts as a structural support, but is also a very strong osteogenic support. And we curate out the entire necrotic area of the bone. And then he also had the right hip done. And his pain at follow-up of 10 and 8 years, he's got an excellent range of motion. He works actively as a kindergarten teacher now, and he's got some restriction of internal rotation on the right side, but otherwise he's pretty happy. Here's another example of a 44-year-old pharmaceutical sales executive who was a smoker, some social alcohol consumption, but I would argue it was much more than social. And you can clearly see he's got right hip pain, some cystic change, and a very well-defined avascular necrosis. I completely agree with Jay Lieberman's. In fact, it's a sign that is not really talked about, but it's a very sensitive sign, loss of internal rotation, and you can see he's got internal rotation and loss. But I'm not, so that's a very sensitive sign for avascular necrosis, but I'm not sure whether it necessarily translates into poor prognosis. We use CT for planning. So here's the head is spherical. There's no crescent sign as yet. We identify and locate the extent of necrosis, and our approach is anterior medial. So we can make a trough on the neck and curate out all the necrotic bone and then slot in the graft. So it's important to understand that the medial circumflex artery is a very prominent player in the vascularity of the femoral head, and we make our best attempt to try and preserve a majority of its branches. So here's the surgical approach.
In the supine position, the sandbag under the buttock, good exposure to the iliac crest.
So that's the planning, that's the incision from which we approach the hip joint. So that's the femoral artery.
We usually do.
That's the we put a sling around the vessels. That is the inferior epigastric, and the vessel is very easy to find. Once you identify inferior epigastric, the deep circumflex is just opposite the inferior epigastric. So that was a graft, the vascular bone graft was done. He was partial weight bearing, walking in 4 to 6 weeks' time. We allow free hip movements, and you can see the graft is very well integrated, and the remodeling continues. He's back to work within a year's time. And we then do a CT evaluation that's already a couple of years. The graft is very well integrated, acts as an osteogenic and structural support. We also use MRI assessment using a perfusion scan, and the graft remodeling continues for several years, but there's progressive integration and replacement of necrotic bone, and it's quite sensitive, although this is more a research technique, because in the service setting is very difficult. This perfusion MRs take quite a bit of time, and they require quite a bit of manpower and equipment. So, but there is evidence that there is high perfusion in the bone graft and low perfusion in the necrotic bone, and we are able to change that. Here are some long-term results. A 45-year-old with single application of steroid cream had hip pain, had developed stage 3 avascular necrosis, and at 14 years, she's got full range of motion of the hip. Here's a CT showing her graft as a very good subchondral support, and that's a range of movement. Again, another, I think I'm going to, I forgot to so that is where we have, we have the source that we detach. We make a tenotomy of the source after we expose the hip. So we are now exposing the hip. We've gone onto the medial side of the hip joint. And you can see that's the femoral head, and that's the femoral neck area. So make a trough in the femoral neck, and from there we can actually extend the trough a little bit onto the femoral head so that it doesn't affect the articulating part. And that's the trough that's made, and into that, after we remove all the necrotic bone, we can slot in our bone graft. So we also use a lot of cancellous bone, and that's the bone graft. It's pretty solid. It's very robust. The pedicle is very, very strong, and that's the graft that is slotted in. And you can see the pedicle is pretty okay. No need for any anastomosis. So here was a medical officer who developed avascular necrosis and massive infarcts because of SARS and the steroid bolus. At 6 years, the femoral head was still spherical. And at 12 years, there has been some collapse, but her pain is manageable. She almost has no pain. She drives. She has now taken to cycling. There's some restriction of terminal internal rotation. She definitely doesn't want replacement, although you can see there is evidence that the hip is going to be arthritic. But it's 12 years, and she's very, very happy. Here's another example of stage 3B. Now, at 3B, you would have rapid progression, and those days there was nothing else available. So we would go ahead with, especially younger patients, go ahead with a vascularized bone graft salvage. And here you would argue that the salvage is successful. The head has become very sclerotic. And there's not much pain, but limited range of motion. Patients accept it, and you would see in stage 2, our results are 66% at 6 years. Once it goes to stage 3B, it's actually gone down. Not 44%, it's now something like 30%. But remodeling is a phenomenon that is amazing. You cannot explain that sometimes, and therefore, I would be very cautious in interpreting without taking into account the patient's activity, his own preferences, and decide really what you want to do. Do you want a head salvage, or is it worth doing a hip replacement early on? So that's something we leave patients to think about. And here's a fireman who's had a vascularized bone graft. At 20 years, you can see he's got the head is still viable. He's got evidence of arthritis, but he doesn't want his hip to be touched, and he's completely pain-free. He's got 90-degree range of motion at the hip. This is the opposite side. He's done that was now 18 years, but it's actually much better because that was done at a stage earlier than the left side. So both femoral heads were salvaged. He's retired. He's pretty active, doesn't want any replacement. So remodeling is phenomenal. Here's again stage 3 case. At 24 years, the head is remodeled phenomenally. And I think our current case selection, we are quite selective because I'm not a hip or a joint replacement surgeon. My major surgical goal is oncology treatment. So I do mega prosthetic and all kinds of oncology reconstructions. I inherited this because nobody else does this. So we are very careful now, very, very selective. We do that for young patients, pre-collapse or very early collapse, no prevalence of major risk factors. And we tend to choose non-alcoholics and those without substance abuse because I think these procedures are not without risk. So I want to do something in patients who have a fighting chance of benefit and recovery. And I think most revisions happen between 3 to 6 years. At 7, 8, 10 years, patients start to accept this, and they are probably. I'm not saying that patients won't have a revision after that, but they stabilize at about 7, 8 years. So you can see we have a 60% success rate, and it drops down as the stage progresses. And in our stage 3B, our success rate has come down to about 20%. I think one of my colleagues is just reviewing the data and is trying to send it for publication. So I'm going to stop here, and I'd be interested to hear all your views as well.
Well, thank you, Shekhar. I mean, just the magic in your hands. I think that's what's happening when we see these kind of cases. Totally magic. You have revascularized the avascular. And, it is technique, it's diligent work, and you need someone like you. And I think in the hands of mere mortals, like I've been saying, we have other things that we can do. Maybe just do hip replacements.
Yeah, Shekhar, we are just carpenters, aren't we?
Yeah.
You are the real artist. You're the real...
No. I think taking into consideration everything. I think it's very important. All the modalities are important. So I think Sanjay, your presentation is quite important because it is counterintuitive. You want remodeling, and now you are inhibiting remodeling, but for a controlled and a small reason, and I think the result is pretty convincing. So I might say, look, instead of going into this complicated surgery, better try this before, because you can always get back. And
exactly, in your slides, you showed that area which is softened after avascularity, where you get the neovascularization. That's clearly what causes the collapse. And if we can get the drugs in there to prevent that collapse, then you might save the hip, because there is neo-osteogenesis happening. So, Shekhar, whilst we are waiting for the questions, etc., the question has come: when does the patient become ambulatory without support? In your cases, where you've done this, and may I request in the meantime, Dr. Desai, to be ready with his very short presentation.
So our patients are now touchdown ambulatory. As soon as their drain is out, we put them touchdown ambulatory, because we really don't compromise the structure of the hip. Right. So they are touchdown ambulatory, and usually they resume weight bearing by about 4 to 6 weeks.
Great.
And the only muscle we cut is the iliopsoas.
So Dr. Hemant Wakankar and I have decided that this is a great webinar. You're all doing it from home in any case. So we are going to extend it by another 10 minutes. And we have Dr. Desai, who is going to, from Surat, show...
I think you need to stop sharing your screen.
Oh, yeah, sure.
Please.
And he's got a system by which he has worked on this for 20 to 30 years. Dr. Desai, are you there with us?
Yeah, Dr. Desai is a very senior orthopedic surgeon with, I think, he's been practicing since I was born, I think. So he's a very senior orthopedic surgeon, and he's got a 30-year follow-up of some of his patients, and we thought it would be relevant for him to present in this webinar. So we just got a very brief presentation. Dr. Desai, you there?
Thank you very much. I thank the Indian Society of Hip and Surgeons office bearers for this opportunity. We had studied a retrospective study of core decompression done for pre-collapse non-traumatic osteonecrosis of femoral head. And we had a follow-up of 1.5 years to 30 years, average follow-up of 8.5 years. There are 35 hips and 24 patients. The idea of the aim of the study is whether it is effective and what are the factors that decide the outcome. So we don't have any management. We cannot do anything to change the etiology. All of our patients are Picarta and Arledge stage 2, pre-collapse. So we have to concentrate more on the location of the lesion, the size of the lesion, whether it is mainly sclerotic or lytic, and whether bone marrow edema has any effect on the outcome. So we decide the size, the extent of the lesion by modified Kerbal method. There we decide the combined necrotic angle, which is sum of the arc of necrotic area in the femoral head in mid-sagittal and mid-coronal images. The location of the lesion is very important, as it has already been pointed out by Dr. Lieberman, and we have followed the Japanese Investigation Committee classification, where if the lesion in the femoral head is in the medial part of the acetabular weight-bearing surface, it is 1/8. If it is in the middle and medial, it is type B. If it is in medial, middle and lateral, it is type C1. And if the lesion, extent of the lesion goes beyond the lateral margin of acetabulum, it is C2. And it is very important that C1 and C2 makes the lateral pillar, and integrity of lateral pillar makes the susceptibility to collapse. So our technique is in a supine position, we do 2 drills by 4.5 mm cannulated drill into the necrotic area and 1 more drill in the center of the femoral head. We have not used any bone, the mesenchymal cells or anything in this particular study. And certain case presentation. This alcoholic man, 40 years old male, this is his perioperative radiograph, which practically shows that it is normal, but his MRI shows that there is a combined necrotic angle of 380 degree on right side and 410 in the left side with C2 location. The location of the lesion is C2. See, it is beyond the margin of the acetabulum. And within 2 years, he just collapsed and required total hip replacement. On the contrary, this man, 26 years old male, is idiopathic avascular necrosis. His lesion is central in location and he has only 180 degree of combined necrotic angle. And after 22 years of core decompression, he has normal hip radiologically and clinically. And here, this is steroid-induced 34 years male. He has a combined necrotic angle of 190 degree. And the location is C1, so that is little not favorable. So what has happened? He has, for 18 years, this hip served him, but then it started paining him, and it is the pain. Hip has not collapsed, but it has become arthritis, and he needed total hip replacement. So importance of lateral pillar. Here, he is a man, he has lymphoma, he was on chemotherapy, steroids, he is HIV positive, and this is his X-ray after 10 years of core decompression. The way he walks is normal. He has no complaints. He is able to sit cross-leg and squat. Though there is some changes in the hip, but he is quite comfortable. So the importance of Sylvian location that we want to stress. All hips that have collapsed in 2 years of index surgery had combined necrotic angle of more than 290. In all of them, the location of lesion was C1 and C2, and they have bone marrow edema. This is a very poor prognostic sign, is already pointed by Dr. Lieberman, and infusion. And it has, in 2 years, it required total hip replacement. Here, the opposite contralateral hip, which was symptom-free at presentation, has ultimately progressed to deteriorated in 2 years. So, in our case, 50% of asymptomatic contralateral hips have deteriorated. These all hips who have combined necrotic angle of less than 190 degree with location central in an intact lateral pillar, majority of them are sclerotic and they do well. These 2 hips, he has combined necrotic angle in 4 hips in 2 patients, combined necrotic angle 250 degree. They have collapsed a little, but ultimately stabilized because the lesion location was C1 and not C2. And so they have satisfactory result. The Murley-D oblique score is 10. So these patients who, if correctly selected core decompression, it prevents or delays the total hip replacement. This procedure is simple, safe, economical, and within the reach of average orthopedic surgeon, and it does not jeopardize the future total hip replacement. So it is indicated in those patients who have combined necrotic angle of less than 200 and intact lateral pillar. Guarded prognosis, if necrotic angle is between 200 and 30, first the intact pillar will help them. There should be low threshold for core decompression for contralateral asymptomatic hip, and close follow-up is required. The procedure is contraindicated in combined necrotic angle is more than 300 and lateral pillars involved. Use of stem cells may increase the indication of this core decompression. I thank you for your attention. Thanks.
Dr. Desai, outstanding. I mean, you've shown us 30-year results, and there are really convincing pictures. I think this Kerbull method and then the technique that you used, I think we salute you. We have time for Dr. Amish Kshatriya to make a very brief presentation. If you could, Dr. Kshatriya, could we get Dr. Kshatriya to share his screen? And this is the problems that they face after a fibula has been put into the neck, and then they need to do a revision and how they tackle this. Thank you, Dr. Kshatriya. Yes, please go ahead. We're really short for time right now, so we appreciate you making the brief presentation. Amish? We can't hear you, Amish. We can see your screen. We can't hear you. You have to unmute yourself, please.
Dr. Amish, sir?
Yes.
Yeah. Thank you, sir.
So we have learned a lot from the great speakers. We have used the vascularized fibular graft, the iliac crest, and all the techniques. Now, especially, I will focus on the surgical technique of removal of this fibula. Now, once the patient has got problem, and we are ready, the patient is arthritic and has a lot of pain, and once he is ready for total hip replacement, then this fibula can come into our way, and it can act as a big culprit. So, okay. The complications which can occur are the perforations and the fractures and the varus placement of the stem, and sometimes which can jeopardize the implant fixation and can later on impact the survivorship of the implant and can affect the longevity of the implants and can lead to aseptic loosening. So this fibula has to be removed very precisely and very properly. So here is the technique. Here you can see we cut the neck with precaution that the sclerotic fibula, here you can see this, it has to be drilled first from all the sides. This I have used the anterolateral approach. Then after gouging, making a drill hole and passing a K-wire through the fibula, and we keep a finger on the opposite lateral cortex so that we are in proper line. And then we take out the K-wire from the lateral cortex and we go on drilling with the 2.7 drill bit, making a round and drilling in line with the this of the K-wire. The drill should be parallel to the K-wire. So and again we gauge it from the lateral cortex also, and little bit we have to be patient. We should not be in a hurry. So this is from the lateral cortex. Then again we come in front, and then again we gauge it. Final gauging with you can use small gauges to so that the fibula stud graft comes out intact. And this is very important because if it is not removed completely, then it can lead to some perforation and may lead to weakening of the trochanter and can lead to fractures. And after performing this, there is a big gap which has to be filled by the graft, that we take it out from the femoral head or the fibula that we have taken out. We can cut it and we can again put it back after doing the total hip replacement. So this was the immediate post-op, and here the graft was filled. And this type of complications can be prevented by removing the fibula graft with this technique. Now we have done a lot of these 7 to 8 cases, and this is a 18-year follow-up. And this technique we learned from Dr. Pachore, who is head of department and director of hip surgery at Shelby Hospital. And I thank you for the opportunity for sharing me this technique.
Thank you very much, Amish. Very intuitive. And the need to remove the fibula so that you do not misdirect your instrumentation and your femoral prosthesis. Excellent. I think Dr. Hemant Wakankar, at this point in time, we need to thank all our participants for having joined from different parts of the world. We still have Dr. Jay Lieberman, who is here. We've kept you awake overnight and now in the morning, Jay. But which was a great talk. And to have Dr. Kumta from Hong Kong, to have Professor Chang from Seoul, and to have you, and of course, Dr. Mont, who's no longer on the panel, along with the rest of the people. We have had, I believe, close to 800 to 900 people who have joined in from time to time for this particular thing. At the end of this, we will know the real number, but that's a very large number of people who have, made an effort to hear this. And Dr. Wakankar, what do you have to say?
No, I think all in all, wonderful learning experience for all. I mean, we all have learned from each other, and I think this is a wonderful way of educational activity and getting all people. I think what may happen actually is that the in-person conferences will probably go down. I mean, people will realize that this is a wonderful way of learning, and travel will go down. All the issues related to travel and contact. Obviously, personal touch is not there, but all in all, it's quite a liberating experience to be relating to all of you. So wonderful. I would love to thank all of you personally, but I can't. It has to be virtual. So yeah, and thanks Mojib as well for logging in, and with some difficulties with logging in. But yeah, Dr. Lieberman and Dr. Mont, thank you all very much. And Shekhar, as always, wonderful. It was wonderful. And
Thank
Dr. Chang, I think, is just, I think he's there, but I think his video is off. Dr. Chang, Professor Chang from Korea, thank you very much. And obviously, the two presentations we've had, Dr. Desai, who's now we can see in person, and Dr. Amish, wonderful presentations as always. And I think this webinar will continue on a monthly basis. Next one we are planning in a month's time, just before Diwali. And that's going to be on complex knee deformities. And we are organizing the faculty for that. And look forward to all of you joining again at the same time. So all in all, thank you very much. And wonderful to have you all here.
Great job. Thank you.
Thank you.
Bye. Bye.
Thank you. Bye-bye.
Thank you. Thank you. अच्छा, आज बताओ मेरे बोर्ड से।
So with your permission, can I go ahead and end this webinar, sir?